Dr. Mukherjee, are we ready to start? Your mic is muted, just an FYI.
Can you hear me now?
Yeah, I'm just going to make a couple of announcements and then we'll get started. How does that sound?
Sure.
Perfect. Good morning, everyone. My name is Chris. I'll be the moderator this morning. Just a few announcements before we get started with our virtual cardiac rounds. The presentation is being recorded. During the presentation, make sure your microphone is muted at all times. Questions will be answered at the end of the presentation, either using the raise your hand function, or you could type the questions into the chat and then I'll ask them to Dr. Mukherjee. This morning, Dr. Mukherjee will be speaking about COVID and the heart. It's all yours, Dr. Mukherjee.
Thanks, Chris. So the topic is quite timely. As you know, we've completed the first wave of COVID, and as of October, we're headed into the second wave of this pandemic. So it's very important as the Regional Cardiac Center that we understand what the implications of COVID are from a cardiovascular perspective. So today we're going to look at current demographics, including Ontario. We'll talk a little bit about the biology of the virus. We're going to look at a broad spectrum of the cardiovascular manifestations of the disease. And with each, we'll look a little bit at what we understand regarding the mechanisms of cardiac injury. We're going to talk a little bit about the use of traditional therapies for cardiovascular disease in patients who have COVID. So currently in Ontario, as of last week, we had about 62,000 confirmed cases. On a daily basis, we were reaching 800 new cases per day, the highest we've seen since the summer. Some of that certainly is due to the increased availability of testing, but still it serves as a guide to what we can expect in future in terms of hospital admissions and mortality. So case characteristics tell us that about half cases are male and the other half are female. About a quarter of patients are over the age of 60, and uncomfortably about 11 or 12% of all cases occur in healthcare workers. We still have a percent positivity rate of about 3, which isn't ideal, but it's not the worst. We've done about 39,000 tests in Ontario. I don't know if that number is right. Sorry, that's 39,000 tests per day in Ontario. And we can see the trend in test positivity over time, that we had our initial peak here in late spring, early summer, line with social distancing measures and lockdown that the province imposed. But as restrictions relax, we see again a rise in the number of cases. In comparison to other provinces in the country, we have a disproportionate number of cases that are involved in healthcare workers. So Quebec has the highest of 14,000 healthcare workers affected, representing 24% of all cases. The majority of these are in retirement homes and long-term care facilities. Similarly, in Ontario, 6,000 cases have occurred in healthcare workers, representing about 17% of all cases. And these two provinces lead the country in terms of healthcare workers affected. It's important for us, again, as a cardiac center for our region, that we establish protocols and good practice measures that reduce the transmissibility from affected individuals to our healthcare workers. So a little bit about the biology of the disease. The virus is known as a coronavirus, and the terminology is COVID-19 is the clinical disease itself, and that disease is caused by SARS-CoV-2, or severe adult respiratory syndrome caused by coronavirus 2. Coronaviruses share the similar physical properties that they are an RNA virus, so the nuclear material within the viral capsid is RNA. It has on its surface this very unique S protein, which serves as the binding protein to the human cells. Within the genome of the virus, there are 2 coding regions, one for non-structural proteins and one for structural proteins. And compared to SARS-CoV, the original SARS virus of 2003, we see there are some mutations present in this second version of the virus contained within the receptor binding site, and also some other mutations within the S protein site. So the life cycle of SARS-CoV-2 looks like this. The S protein is activated by a membrane protein found within oral mucosa and respiratory epithelial cells, the so-called TMPRSS2 protein. And this protein primes the S protein located on the coat of the virus, such that it particularly has particular affinity to the ACE2 membrane protein. And ACE2 does stand for angiotensin converting enzyme 2 protein. So it is involved in the renin angiotensin aldosterone pathways. The majority of the virus enters the epithelial cells through this mechanism and injects its RNA directly into the cytoplasm, where it is then transcribed initially by cytoplasmic enzymes, but very rapidly this PP1A and PP1AB proteins are translated and then cause RNA-dependent RNA proteolase, which transcribes the RNA protein, makes further copies of the viral RNA. At the same time, the RNA genome is transcribed and translated by the endoplasmic reticulum into the coproteins M, E, and P. The coproteins then are recombined and assembled with the transcribed viral RNA into discrete viral units, which are then released through this endocytosis exocytotic process. There's a second mechanism by which the virus can enter human cells, and this mechanism is seen more commonly in petri dishes, in vitro experiments, where instead of injecting the RNA directly into the cytoplasm, the viral particle fuses with the cell membrane in a process of endocytosis, and then the viral RNA is released. Although we see this in vitro to a good extent, we're not sure how much of this process occurs in vivo. Interestingly, the drugs remdesivir and hydroxychloroquine act to prevent endocytosis of viral particles. And we'll talk about those medications a little bit later on. Now, the ACE2 protein, which serves as the receptor for the viral particle, is distributed broadly throughout human cells, but it's most prevalent in organs like the lung, heart muscle, and colon. The clinical phases of COVID-19 can be broken down into 3 stages. The early infection stage, or so-called stage 1, is the viral response phase. So we see a lower severity of illness, and most of the illness is caused by direct viral injury to human cells. In stage 2, the so-called pulmonary phase, this can be divided into 2 phases, but we see a combination of direct viral injury, but also we start to see increasingly injury due to host inflammatory responses. Finally, in the worst severity of cases, so-called stage 3 or hyperinflammatory phase, the predominant mechanism of damage is caused by the host inflammatory response to the virus. In terms of susceptibility and transmission of the disease, what we've identified is that most of the transmission occurs in patients who are pre-symptomatic. In fact, 47% of transmission occurs prior to the onset of symptoms. 38% of transmission occurs from individuals who are symptomatic, exhibit the typical respiratory symptoms or fever. 6% of transmission occurs in asymptomatic individuals. Now, these three groups together, the transmission is through viral-laden droplets or aerosol particles that are emitted into the air. Typically, we say that you need close contact, meaning less than 2 meters, close contact with an affected individual for more than 15 minutes to make the likelihood of transmission, reasonable. There is about 10% of infections that occur through environmental causes. In other words, an infected individual touches an object which isn't cleaned. The person to whom the virus is transmitted then touches that same surface, picks up the virus, and then self-contaminates. The greatest density of viral load contained within respiratory expectorant or aerosolized particles actually occurs a couple of days prior to symptom onset. The problem with COVID-19 is that there's a long latency with respect to the development of symptoms. So two things, influenza and the first SARS epidemic that we had, the patients weren't contagious until they were symptomatic. So that isn't the case with SARS-CoV-2, which makes it particularly problematic. And secondly, there's a latency between onset of the disease and onset of symptoms, and that latency can be anywhere from 5 days all the way up to 14 days. And that's why we recommend the 14 days of isolation should you come into contact with somebody with known COVID-19. So the second stage of COVID-19, the pulmonary phase, can be divided into two stages, stage 2A and stage 2B. In stage 2A, again, most of the damage is from the direct effect of the virus. And in stage 2B, the predominant damage is done by increasing degrees of an inflammatory response. Finally, in stage 3, we have the sickest patients. These patients often need some sort of respiratory support, very commonly mechanical ventilation. Now, in addition to the pulmonary and respiratory effects of SARS-CoV-2, we see a large number of patients who have cardiac manifestations. And there's an interplay of traditional forms of cardiac disease, acute coronary syndrome, congestive heart failure, arrhythmia. There's an interplay between that and patients with COVID-19. There's an interplay between the acute illness and its effects on cardiac myocytes and cardiac rhythm. We know very clearly now that the comorbidities typically associated with heart disease, increasing age, hypertension, diabetes, coronary disease, heart failure, atrial fibrillation, and cerebrovascular disease, these comorbidities greatly increase the likelihood of mortality in patients who have COVID-19. And just to throw some numbers on it, hypertension increases your risk of mortality anywhere up to 6-fold. The presence of coronary artery disease increases your mortality anywhere up to 10-fold. And so what I'd like to look at now is specifically what are the cardiac manifestations of COVID-19 and how do patients with traditional ischemic presentations fare in the setting of COVID-19. So we'll look at myocardial infarction type 1 and 2, stroke, arrhythmias and cardiac arrest, heart failure. This burgeoning concept of acute non-ischemic myocardial injury. We'll look at kids and a Kawasaki-like syndrome. There's some data looking at endothelial inflammation and thrombosis, and a recent study, an MRI study, looking at delayed or subclinical myocardial injury. So one would expect with activation of the inflammatory thrombotic pathways seen in COVID-19 that there would be an increase in the incidence of STEMI presenting to hospital during the pandemic. But interestingly, there's been no increase in the incidence of STEMI. In fact, STEMI has the admissions to hospital with acute myocardial infarction during the pandemic have decreased. And this is certainly because of changes in patient behavior. There's a reticence or a reluctance, a fear of patients coming to hospital that they might be exposed to COVID-19. And so many patients ignore their symptoms or delay presentation to hospital. Outcomes of STEMI and NSTEMI during the pandemic vary quite a bit depending on the study you read. So there are studies out of Europe, including the UK and Sweden, and studies out of the United States. And there is a divergence in what's going on in terms of outcomes. In Great Britain, there doesn't appear to be any increase in mortality from myocardial infarctions that present to hospital. Similarly, in Sweden, there's been no change in outcomes. However, in the United States, despite a declining incidence of hospital admission for myocardial infarction, they're seeing worse outcomes. And again, this may be related to the fact that patients are presenting later in the course of their myocardial infarction and therefore present with a greater burden of complications, including heart failure, cardiogenic shock, et cetera, et cetera. Now, anecdotally, I just finished my CCU week last week. And, you know, in a typical week, we might see 0 or 1 late presentation of MI. But last week we had 3. So that's some anecdotal experience. With respect to type 2 myocardial infarction, this is the MI that's caused by oxygen supply demand mismatch. And these represent the majority of myocardial infarctions seen with COVID and relate not so much to the cardiovascular system itself, but more primarily to the infection, the hemodynamic compromise and respiratory compromise that occur as a consequence of the infection. Nonetheless, the presence of type 2 myocardial infarction in the setting of COVID-19 does increase the risk of mortality. These patients are managed primarily by addressing the underlying disease process and correcting any hemodynamic or respiratory derangements that occur. So here's just some graphical representation of the volume of presenting acute coronary syndrome. This is in Great Britain, and you see that for any acute coronary syndrome, we see a fall in the numbers. I think this hatched line is when England went on lockdown, and so the nadir occurred just after lockdown, And then subsequently in the early spring months, we see a return to baseline of acute coronary syndrome presentations. So this includes STEMI, NSTEMI, unstable and crescendo angina. If you just look at STEMI and NSTEMI, again, you see a similar pattern with a fall in the frequency of presentations reaching a nadir just after lockdown, and then a more gradual return to baseline. Interestingly, with ST elevation myocardial infarction, there's much less of a pronounced reduction in presentation. And this is likely due to the fact that symptoms of STEMI are much more severe and unremitting than are the symptoms of unstable angina or NSTEMI. Similarly, in the United States, this data comes from Kaiser Permanente in California. In 2019, seen by this yellow line, we see that there is a seasonal variation in presentation of myocardial infarction, where MIs present more frequently in the wintertime with a mild and gradual decrease in presentation frequency as we approach the warmer months. But in 2020, we see a much more dramatic fall in the numbers presenting with MI through the seasons. And this coincides, of course, with the increased rates of COVID-19 seen in the community. So as COVID-19 increased, there was growing fear amongst the patient population and a greater hesitancy to present to hospital with myocardial infarction. So if we move on to stroke, the other large ischemic thrombotic type cardiovascular presentation, we see that ischemic stroke accounts for almost 80% of all patients presenting with stroke having COVID-19. Hemorrhagic stroke accounts for 15%, cerebral vein thrombosis 4.4%, and subarachnoid hemorrhage 1.9%. This is in about 700 patients, consecutive patients presenting with neurologic symptoms with COVID-19. So the incidence of stroke in this patient population, overall incidence was 1.8%. In-hospital mortality for all stroke was 34%. Specifically, in-hospital mortality in ischemic stroke was 45%. They did an interesting analysis of ischemic stroke in patients under the age of 50. Not surprisingly, they found that in this patient population, a large proportion of patients had no risk factors for stroke whatsoever. The remaining patients predominantly had hypertension as their risk factor. Atrial fibrillation was not seen in any of the stroke patients under the age of 50. And this is really scary. Patients that presented initially with stroke, in 50% of cases, had no COVID symptoms at the time of stroke presentation. Also, very interestingly, large vessel occlusion, meaning occlusion of a carotid artery, middle cerebral artery, anterior cerebral artery, occurred in the vast majority of patients, young patients presenting with stroke. So whether this large vessel occlusion is de novo within the cerebral arteries themselves or clot formation elsewhere in the body that then passes through a PFO and causes stroke, that kind of mechanism couldn't be elucidated in this study. Moving on to cardiac arrhythmias, there's a study out of New York that looked at a total of 700 patients admitted to hospital with COVID-19. The mean age was 50 years of age. 45% were 45% were male, 70% were Black. Of the 700 patients admitted to hospital, 79, or about 11% of patients, required ICU care, and the mortality in that population was 23%. The remaining patients, 621, were admitted to non-ICU settings, and the mortality was about 2%. At the time, these New York State patients, a large portion of them did receive either remdesivir or hydroxychloroquine as part of their treatment regimen. All cardiac arrests in this patient population occurred in those patients admitted to the ICU. However, the majority of cardiac arrests were non-shockable events. If you were admitted to ICU, they observed a 10-fold increase in the risk of arrhythmia. And cardiac arrest was associated with an increase in hospital mortality. The characteristics of patients, the characteristics of patients with cardiac arrest, we see that the vast majority were pulseless electrical activity. 2 were asystolic arrests. Only 1 was a rapid a tachycardic type of arrest. This was torsade de pointe in a 42-year-old obese patient on ECMO and who had respiratory failure and was ventilated. We see that patients admitted to the ICU had a larger burden of comorbidities. They were older than patients in a non-ICU setting. They had 3 times the rate of coronary heart disease. They had twice the rate, or almost 3 times the rate, of heart failure. They had twice the rate almost of hypertension. They had increased prevalence of diabetes, obstructive sleep apnea, chronic lung disease. We also see that biomarkers in the ICU patients were more commonly elevated than those in a non-ICU setting. So here they use the reverse of elevated troponin. They look at non-troponin concentration, non-elevated troponin concentration. Then they see that fewer patients in the ICU had non-elevated troponin versus those in a non-ICU setting. Similarly, BNP was increased more often in the ICU than on the ward. So these were clearly sicker patients, those in the ICU, than those on the ward. And not surprisingly, therefore, rates of atrial fibrillation in the ICU were higher than on the ward. Bradyarrhythmias were higher in the ICU than on the ward. And non-sustained ventricular tachycardia was higher in the ICU than on the ward. In the end, the authors concluded that the increased rates of cardiac arrhythmia seen in a COVID population was less likely to be due to the direct effect of the virus and the inflammatory response, and more likely to be related to the severity of illness. So the sicker you were, the more likely you were to have an arrhythmia, similar to other disease processes that cause severe illness. Let's talk a little bit about heart failure in COVID-19 patients. This study comes from Spain at the height of their pandemic. And so some of their results, I think, have to be interpreted with a little bit of caution. So in this study, they screened 5,000 patients with clinically suspected COVID-19. They only analyzed those patients who had confirmed PCR confirmed infection, and they had complete at the end in about 3,080 patients. They found that in that cohort of 3,000 patients, about 150 had a prior history of congestive heart failure. And those patients with a prior history of congestive heart failure, here shown in red, had much worse survival with 50% mortality at 80 days versus those patients with no prior history of heart failure who had a much better survival, um, more like 75% at 80 days. They also looked at patients in the cohort who developed acute heart failure in hospital, and they had about 77 of those patients. And again, they found that development of acute heart failure in hospital was associated with decreased survival, down to about 50% at 80 days, versus those patients who don't develop acute heart failure in hospital. They have a much better survival, over 75% survival at 80 days. This is a very telling, these are some very telling graphs. In patients with prior congestive heart failure who are admitted to hospital, if medications were withdrawn, they did very poorly. So if your ACE ARB was withdrawn, you had a 75% mortality versus if they were maintained, mortality was only 25%. Similarly with beta blockers, there was a less than 25% survival if beta blockers were withdrawn versus about 60% survival for those who remained on their beta blocker. And with their mineralocorticoid receptor antagonists, again, we see much better survival if the medication is maintained. What's not clear from the study, so withdrawal of medication in a multivariate analysis was corrected for other comorbidities and age. But what's not clear from the study is whether severity of illness predicted those patients in whom medications were withdrawn. And if that were the case, in other words, you withdrew medications in the sicker patients, then we wouldn't know whether it was the withdrawal of the medication itself or the severity of illness that led to the observed increased rates of mortality. So factors within the study that predicted the presence of heart failure were age. So for every 5-year increase in age, there was an increase in the incidence of heart failure, acute heart failure in hospital. Similarly, atrial arrhythmias predicted the development of heart failure. If you had pre-existing heart failure, you are more likely to develop acute heart failure in hospital. Any type of bleeding led to an increased rate of heart failure, and the presence of chronic obstructive lung disease was also associated with the development of heart failure. Other takeaways from the study were that overall there were only 2.5% of patients admitted with COVID developed acute heart failure. The authors suspected that the rates of diagnosis of heart failure may have been reduced because the time in Spain, the facilities were inundated with sick patients. And so there was quite a bit of limited contact between healthcare workers and the patients themselves. So they suspect they might have missed the diagnosis of heart failure in a lot of patients. The majority of acute heart failure cases, almost 80%, developed in patients without a prior history of heart failure, suggesting that the inflammatory response to COVID may have deleterious effects on the heart without pre-existing heart conditions. The proportion of patients developing acute heart failure was higher in the CHF group. So 11% of patients with pre-existing heart failure developed acute heart failure in hospital versus only 1.8% of patients without pre-existing heart failure. CHF patients were less frequently admitted to the ICU, 2.1% with heart failure versus 8% without heart failure, and less often received mechanical ventilation, 2.1% versus 7.6%. And this clearly is counterintuitive. We would have expected that if you developed heart failure, you would be more likely to get admitted to the ICU and more likely to receive mechanical ventilation. The authors explained that CHF patients in their series were older, as we saw in the previous slide, and had more comorbidities. And because there was limited resources available during this surge of cases in Spain, they reserved ICU admission and mechanical ventilation for patients whom they thought had the greatest chance of surviving. Typically in Spain, mortality rates per year in patients admitted with acute heart failure without COVID approach 17%. In this series, mortality in patients with heart failure and COVID was almost 50%, versus a 20% mortality in patients with COVID and no heart failure. So heart failure is really a strong predictor of mortality in this patient population. I'd like to talk a little bit about acute non-ischemic myocardial injury in COVID-19 patients. And there are three major types, and actually some more that we'll be discussing, but stress cardiomyopathy, lymphocytic myocarditis, and we'll look at other mechanisms of myocardial injury, which actually turns out to be the greatest driver of myocardial injury in COVID-19 patients. So not surprisingly, COVID-19 is a huge stress to our system, and correspondingly, we see an increase in the rates of stress cardiomyopathy, or Takotsubo's disease. And so in this California study, it's a small study, only 2 centers, but it's actually the best data that I could find. In the pre-pandemic setting, only about 2 out of 100 patients presenting with acute coronary syndrome would end up having stress cardiomyopathy. But this number jumps to about 8 per 100 presenting with a clinical picture of acute coronary syndrome in the pandemic era. And this has implications for how we look after our AMI patients. We have to do a little bit more history taking. We might, it might be an idea to employ a quick bedside echo prior to taking the patient to the cath lab. And we want to try and tease out these patients, one, to avoid doing unnecessary procedures on them, and 2, to avoid exposure of the patient to our healthcare workers. You can imagine if our cath lab nurses get taken out of circulation, our whole code STEMI program goes down. So it's really important that we limit exposure wherever we can. So we know there's a bidirectional interaction between cardiovascular disease and COVID-19. And what I'd like to focus on is this area in here, so-called acute cardiac injury and myocarditis. And so there are several postulated mechanisms for cardiac injury. One is through the inflammatory response produced by SARS-CoV-2. One possible etiology of myocardial injury is through direct viral damage to myocytes. And finally, the inflammatory response may take root within the myocardium itself and cause damage that way. So here's what healthy myocardium looks like under a microscope. These cells, these myocytes, are generally about 25 microns in size. They're densely packed together. This is a cross-section of the myocytes, and this is a longitudinal. These are myocytes in longitudinal section. You can see that there are very few other types of cells. There are few scattered interstitial cells. Um, there are no inflammatory cells in normal myocardium. Here's what the worst cases of lymphocytic myositis look like in SARS-CoV-2. You can see that the myocardium in these upper slides are diffusely infiltrated with lymphocytes. And so you can see all these nuclei that are not associated with myocytes in all of these images. You can have multifocal lymphocytic myocarditis, as seen here in the second row of slides, where instead of the lymphocytes being diffusely distributed throughout the myocardium, you see them in multiple pockets. And where you see this accumulation of myocytes, of lymphocytes, you see significant damage to the myocytes themselves. And an earlier stage, you see less dense aggregation of the lymphocytes, but you still see myocyte necrosis due to the lymphocytic infiltration. Now, while lymphocytic myocarditis is the most severe form of myocarditis seen with COVID-19, fortunately, it's not that common, occurring probably 1 in 7 or less of patients who demonstrate significant myocardial injury. More commonly, we see an inflammatory pattern that consists of macrophage infiltration in the interstitial space. So here we see edema of the interstitial space, and that interstitial space is filled with macrophages. So the distance between myocytes is increased compared to that normal slide that I showed you earlier. Here again, you can see lots of edema within the interstitial space. And so this is a less intense form of an inflammatory response. And it's probably the most common form of myocardial inflammation that we see in COVID-19, estimated at up to 86% of patients. This is an interesting study of autopsy cases. This was published earlier in, these cases were identified earlier in the pandemic. They tended to be older patients who died relatively early of their disease. And what this study looked at is the burden of viral particles within the myocardium as expressed by copy numbers per microgram of RNA. And you can see here patients that were autopsies in patients that were SARS-CoV-2 negative, those that had a medium burden or a moderate burden of viral particle load, less than 1,000 copies per microgram of RNA, and those that have increasing viral load, anywhere from a few thousand viral copies per microgram RNA all the way up to about 100,000 copies per microgram of RNA. So this represents increased viral load within the myocardium itself. And we see that with increasing detection of viral particles within the myocardium, an increase in inflammatory response. And so this is relative gene expression, pink being the lightest, dark red being the strongest gene expression, for various inflammatory markers, including tumor necrosis factor alpha, interferon gamma, and the various interleukins. What's surprising from this study, however, is the numbers of inflammatory cells, despite there being a robust inflammatory reaction as evidenced by an increase of these cytokines. The inflammatories themselves didn't appear to be increased when the myocardium was looked at under a microscope. And value in terms of inflammatory cells within the myocardium is greater than 0.05, suggesting no difference, versus a strong indication that the cytokines are turned on within myocardium containing a significant viral load. Interestingly, the cells that are infected with viral particles within the myocardium tend not to be the myocytes themselves, but rather interstitial cells. So here you can see in situ hybridization for the detection of viral RNA, and you can see that the viral RNA localizes to interstitial cells rather than the myocytes themselves. However, you can still see that this is not normal myocardium. You can see that the cells are quite enlarged compared to the normal slide that I showed you. So those normal cells were 25 microns in size. This is 100 microns. So some of these cells are kind of double their normal size. You can see the ratio of nucleus to cytoplasm is markedly increased in some of these cells. And again, there's quite a bit of edema noted within the interstitium. Here's a close-up of the same thing. So the viral particle staining concentrates within interstitial cells rather than myocytes. So they took a representative patient, no cardiac infections with SARS-CoV-2. Again, the myocytes are more densely packed versus a patient with SARS-CoV-2, much more edema. And again, these are lymphocytes, and they're stained for the COAT protein CD3+. And we see that whether or not you have viral particles in the myocardium, there's a relative paucity of inflammatory cells. Here's the slide with cardiac infection. Here's the slide with no cardiac infection. You don't see a lot of lymphocytic infiltrate. Now, there are other ways in which the thromboinflammatory changes of COVID-19 can affect the myocardium. So we see changes in the small vessel. So there's inflammation in the wall of the small vessel. There's thrombin deposition in the lumen of the small vessels, which can then go on to cause a microscopic or microvascular ischemia within the myocardium and damage the myocardium on that basis. You can also see other types of white cell infiltrates within the myocardium, not just lymphocytes, but also eosinophils and mononuclear cells. In a series of 21 patients with COVID-19 and cardiac pathology, they found that changes of RV strain. So this is myocyte necrosis due to pressure strain within the RV. That occurred in 19%. The majority of our RV strain occurred because of pulmonary hypertension as a result of alveoli filling up with pus and fluid, or because of pulmonary thromboembolic events, pulmonary emboli in particular. Focal pericarditis was seen in 20% of patients, endocardial thrombosis in 14% of patients, and we talked about these other three entities already. So there's a broad spectrum of change or myocardial injury that can result as a result of SARS-CoV-2 infection. How do we manage these patients? Unfortunately, to date, there are no specific treatments for myocardial injury directly associated with COVID-19. For patients who have type 1 myocardial infarction, heart failure, or other cardiomyopathies or arrhythmias, we use the best clinical practice guidelines to guide our treatments. And for those with non-ischemic acute myocardial injury, we manage them conservatively with supportive care. Now, hydroxychloroquine, due to our good friend Donald Trump, received a lot of airtime earlier this year. But in the New England Journal in September, they published definitive results of hydroxychloroquine use in patients with COVID-19 and found that it had no effect on overall mortality when compared to usual care. Remdesivir is proving slightly more promising. So in this study, again published in the New England Journal in September, they found that remdesivir shortened the time to recovery in patients with COVID-19 versus placebo. However, there was no difference in overall mortality in those patients receiving remdesivir versus those patients that received placebo. To date, our best treatment for COVID-19 is dexamethasone, and the results are very consistent with dexamethasone in that it reduces mortality versus usual care. It decreases the need for invasive mechanical ventilation versus usual care. It reduces oxygen requirements. It reduces mortality in patients with or without oxygen dependence in COVID-19. A very interesting study was published this summer looking at patients who had a diagnosis of COVID-19 based on positive swab and symptoms. And they looked sequentially at 100 patients that tested positive in a university hospital in Frankfurt. And they found that some very interesting results. Anyways, the cardiac MRI was done on average 71 days after the diagnosis of COVID-19. The majority of patients were treated in a non-hospital setting, 67% versus 33% that were treated in hospital. They found on cardiac MRI that versus age-matched controls, those who had COVID-19 had lower left ventricular ejection fractions, while normal, they were still lower within the normal range, and that was statistically significant. And they had higher left ventricular volumes, again, while still within the normal range, they tended to be towards the higher end of the normal range. In total, 78 patients who had recovered from COVID-19 had abnormal findings on cardiac MR, and this included raised native T1 signaling. Now, I'm not an expert in MRI, but I believe an increase in native T1 suggests either fibrosis or edema, and a rise in native T2 is more specific for edema alone. Myocardial late gadolinium enhancement, which is specific for fibrosis, was also increased. In 3 patients in this study that had a combination of more severe clinical symptoms, a more marked rise in cardiac biomarkers, both BNP and troponin I, and an abnormal cardiac MRI with late gadolinium enhancement. In 3 patients, endomyocardial biopsy was undertaken. And in those patients, they again found the typical findings of lymphocytic infiltrate and interstitial edema, along with swelling of the cardiac myocytes. Some representative images from the cardiac MRI study. Here we see late gadolinium enhancement in the epicardial portion of cardiac left ventricular myocardium. That's this bright white line. And here we see a patient who has fibrosis of both the pericardium with small pericardial effusion, as well as epicardial fibrosis. Now, in earlier studies of cardiac involvement with COVID-19, these studies out of China, we see pericardial effusion in a significant proportion of patients, anywhere from 1 to 5%. And this is with a less sensitive modality, CT chest. So recently, a syndrome in children has been identified related to COVID-19. And we always think of kids as having um, a smaller burden of symptomatic disease. Um, but it's very important to recognize that children can become very ill with COVID, uh, with a Kawasaki-like syndrome called multisystem inflammatory syndrome. It's rare, but there's a series of about 570 patients in the United States. So it's rare, but not uh, insignificant or not substantial number. And so in this syndrome, we see cardiogenic shock, cardiac dysfunction, abdominal symptoms of inflammation and pain, marked elevation of inflammatory markers. Many of the patients had manifestations that overlap with Kawasaki's disease, which is an inflammatory condition involving the coronary arteries. And here we see in a slide mononuclear cells infiltrating the intima of a small vessel within the myocardium. We see in this condition also viral particles invading kidney tissue. So here you can see viral particles in the glomerulus, and also you can see viral particles attached to the basement membrane, and more viral particles in the peritubular space. And that's not surprising, given that earlier we saw that there is a large representation of ACE2 receptors within the kidney. Finally, inflammation of the vessel lining can lead to large vessel thrombosis. So here's a case of a patient with aortitis related to COVID-19, and you see a large thrombus in the infrarenal aorta just before the bifurcation into the iliac arteries. You also see occlusion here of the popliteal artery on the right, and further down the popliteal artery on the left. After thrombectomy, we can see reestablishment of blood flow all the way down to the ankle. But you can very make out a foot here, but you can see the small vessels within the foot still have no reflow. So vasculitis, inflammation of the endothelium, can lead to some pretty dramatic ischemic consequences. In one surgical study at one center, in pre-pandemic times, out of 630 vascular procedures, only 27% of cases were done for acute limb ischemia. However, in the pandemic era, out of 560 projected cases to be done, 171 will end up being for acute limb ischemia. So thrombotic events in this diseases are quite prevalent. Not surprisingly, then, there are some recommendations for prophylactic and therapeutic anticoagulation put out by multiple societies. Most recommend prophylactic dose anticoagulation for patients who have indicators of hypercoagulability, or in those patients who are expected to be confined for a prolonged period of time. And full anticoagulation is recommended for those patients who demonstrate overt thrombotic events and who have hematologic markers for microthrombotic events, so marked increase in D-dimer or fibrinogen. So if we turn back to the RAS system, just to remind ourselves that ACE1 converts angiotensin to angiotensin 2, and it's the site of action of the ACE inhibitors we use, captopril, lisinopril, monopril, etc. And ACE2's function, however, is to break down angiotensin 2, which is a very potent vasoconstrictor, into these other angiotensin particles. And so ACE2, it's considered a protective enzyme. We know that the use of ACE inhibitors and the use of ARBs, which block the receptor site of angiotensin 2, upregulate ACE2, upregulate the ACE2 receptor. And so the thought was that the use of these agents, ACE inhibitors and ARBs, in patients either with increased susceptibility for COVID-19 because of their pre-existing cardiovascular conditions, or in patients with active COVID-19 may be detrimental because the ACE2, of course, is the receptor protein for the viral particle. And so you don't want that upregulated. However, evidence suggests that this probably isn't a major mechanism of worsening disease. And in fact, as I showed you in the other slides, withdrawal of these proven therapies actually leads to increased mortality. So the Curtin guidelines suggest that we shouldn't be withdrawing proven therapies for our patients with cardiovascular disease. Oh, and I think that's the end of our presentation.
All right, Dr. Mukherjee, thank you for that presentation. We're going to go into our question period now. We do have one question already in the chat. In addition to the cytokine storm theory, has there been a bradykine storm theory also put forward? Any comment on that and possible treatments?
Yeah, there has been some speculation as to bradykinin and storm, and some people are recommending treatment with antihistamine blockers such as cimetidine or ranitidine. So there is some use of those medications to try and block the increase in bradykinin that we see. But as yet, I didn't come across any data for that.
All right, we'll leave it open for another minute or two. Again, if for those who want to ask some questions, you can use the raise your hand function, or you could type it into the chat. Dr. Ritchie, you want to ask your question?
Thanks, Ash. That was really good. Is there an interaction between Decadron and other potential therapies, or is its effect non-synergistic to the other care?
Yeah, I don't know the answer to that, Joe. I mean, so you're talking synergistic in a beneficial way. So remdesivir on top remdesivir on top of dexamethasone better than either alone?
Yes.
Yeah, I haven't seen that data. I would speculate that yes, it is, but I haven't seen any of that data.
There weren't enough patients in the remdesivir group to probably tease out a difference in the original report, I suspect.
Right, and maybe the time to analyze the data as well. The reports just came out, within the last 4 weeks, so they might go back and reanalyze the data.
Hey Ash, it's Andrew here. I don't know how to raise my and I'm driving, so you just got to take it like this. Great presentation, really helpful.
Were you looking at the slides and driving at the same time?
I was looking before I left the house, and once I drove, it was just audio only. I've heard about some people kind of considering using things like, because of the arterial occlusion, large arteries, and all that stuff, you think of thrombosis. I've heard of some who started talking about using anticoagulant therapy and that sort of thing, kind of for like a preventative, if they're admitted with certain kind of with COVID symptoms and cardiac history and stuff.
Yeah.
Is that potentially helpful? Is there any kind of...
Yeah, so in the guidelines that I showed, patients who present with COVID-19 symptoms and test positive, who also have rapid changes in fibrinogen levels, D-dimers, those patients, they suggest that you should consider full dose anticoagulation in. So I think there was like, if they present with have an increase in their D-dimers up to greater than 4,000, without overt thrombotic manifestations, you can consider full dose anticoagulation in those patients.
I see. Kind of cut out in the middle of my question. Is it more like a DIC picture, or is it just actual just thrombosis?
Yeah, that's a really good question. It gets very complex, and I tried reading it, and I couldn't understand it clearly enough to be able to describe to you. There are differences. They actually have a syndrome name for it, but so they think it is different than DIC and involves slightly different pathways, and they think the difference will have implications in terms of what therapies you use, but I couldn't really tease out. I mean, some of the pathways that they were describing are unfamiliar to me, so I couldn't really present it in a coherent fashion. So I didn't bother presenting that. But yes, there is a syndrome similar to DIC that is not DIC that has been identified in COVID-19. Does that answer your question?
Yeah, that's cool. Thanks.
We have one more question. Dr. Ritchie?
Maybe I'm misreading it, but in the recovered post-COVID patients, it seems like the number of residual cardiac abnormality or symptoms or overt disease is low. Is that an anomaly of small numbers, you think?
No, I think it's an anomaly of we don't look. So these findings are pretty much subclinical. So the gross findings of slightly decreased ejection fraction, the ejection fraction in those with MRI abnormalities was 53%. Versus a non-COVID cohort where the ejection fraction was 57%. These are MR ejection fractions. So the difference is small. It still falls within the normal range, but that the number is statistically significantly different. So I think what we're detecting is subclinical degrees of cardiac dysfunction and subclinical degrees of a myocardial injury. The implication being that if somebody has COVID-19, should we be following them along in the midterm, or perhaps even longer term, to identify earlier cardiac damage and therefore get them on the appropriate medications earlier? Beta blockers, ACE inhibitors, etc. So that that's a rhetorical question. There's no answer to that question yet, but that's the question that the MRI study raises.
It's just that it seems really similar to the kinds of myocardial and vascular effects you see after severe sepsis, where there are these similar findings, but they're not directly related to the infection. Mostly it's related to cytokines and toxins and stuff.
Right. So the difference is in the MRI study, these weren't severe patients. 67% of the patients were treated as an outpatient, were treated at home. So what they're saying is, yeah, you're right. In severe illness, you get myocardial injury. And we know that myocardial injury secondary to severe illness recovers well. There aren't generally long-term sequelae. This study is saying late after the diagnosis, so this is 70 days after the diagnosis of a relatively mild COVID-19 infection, we can see and measure changes to myocardial structure and function. What the consequences and what the significance, long-term clinical significance of that finding is, we don't know.
All right, Dr. Mukherjee, I think we're going to wrap up today's virtual cardiac rounds. I want to thank everyone. I want to thank you again for speaking today on COVID in the heart. And everyone else, have a good rest of the day.